So now we're going to look into obstetric studies and a little more detail for HDFN. So what is HDFN? We've mentioned before it's hemolytic disease of the fetus and the newborn. So we have maternal antibody directed against antigens across the placenta. These are going to coat fetal RBCs and shorten their survival, which causes anemia. The mother is going to lack the antigen that the fetus has, therefore being able to create those antibodies. And we know that these are inherited from the father because it's how the mother sees them as foreign to her. We can have something called erythroblastosis fetalis in these situations. Just one thing. So during pregnancy, a little bit of anatomy and physiology, the placenta is going to function as the site of oxygen, nutrient, and waste exchange. Serves as a barrier between the maternal and the fetal circulation. This is going to reduce the chance of antigen exposure. ABO incompatibility will lyse fetal cells that do not make it across the placenta, further presenting antigenic exposure. Kind of some built-in protection. During delivery, the placenta is going to separate from the uterus. You'll have a significant number of fetal cells that escape into the maternal circulation. This is called a fetal maternal hemorrhage. This can activate the production of IgG antibodies to the paternal antigens that the baby has inherited. We're not concerned about the maternal antigens the baby has inherited because the mom's body won't see it as foreign, and therefore we won't have an antibody production. For subsequent pregnancies, the maternal IgG can cross the placenta. So we're worried about this because for the initial exposure, we have the antibody that's produced. For the subsequent pregnancies is when we may encounter an issue having those IgG antibodies crossing the placenta. These can cause RBC destruction, which is going to increase our bilirubin, create an enlarged liver and spleen of the fetus, erythroblastosis fetalis, cardiac problems due to anemia. We may have hydrops fetalis, which is edema of the peritoneal or the pleural cavity. For our bilirubin increase, this is conjugated by the maternal liver in utero. The fetal liver lacks the enzymes needed to conjugate the bilirubin. Excess is going to bind to tissues, which may cause jaundice, and it may cause central nervous system damage. Brain damage and caused from increased bilirubin is going to be known as kernicterus. May cause deafness, mental retardation, and death. For HDFN to occur, the mother must lack the antigen. Following exposure to fetal cells or prior transfusion forms an IgG antibody to that antigen. The fetus must possess the antigen inherited from the father, and the antigen must be very well developed at birth, because if it's not well developed at birth, we don't have anything for the maternal antibody to bind to. We have three categories of HDFN: ABO HDFN, anti-D HDFN, and other HDFN. The ABO HDFN is the most common form of hemolytic disease of the fetus and the newborn. It's usually very mild, and this is usually treated with phototherapy. See this happen a good bit. This can be milder due to the poor development of the ABO antigens at birth. You may have a weakly positive DAT with the ABO HDFN. This occurs most often when the mother is group O and with a baby that is group A or B, and it often affects the first baby. So we think about that a little bit and go, okay, my mother's group O, they therefore have anti-A and anti-B. And if we have a baby that's group A or group B, they're going to have the potential to have this usually mild but common form of hemolytic disease of the fetus and newborn. For the HDFN caused by anti-D, kind of we went over in our RH system, this is going to be responsible for the most severe cases. RH immune globulin, though, has decreased this instance dramatically, from a 13% to 1 or 2% or even less. An intrauterine transfusion may be required due to the severe anemia. It may require an exchange transfusion to reduce the bilirubin levels. And this is rarely seen with that first pregnancy, basically due to that amnestic response of having to form the antibody first because anti-D is not naturally occurring. We need to have some sort of immune stimulation for it. So it would affect the second pregnancy or subsequent pregnancies. In other HDFN, any IgG antibody can cause hemolytic disease of the fetus and newborn if the antigen is well developed on the fetal RBCs, because IgG antibodies can cross the placenta. For anti-K, this is especially severe. It's really only second in severity to anti-D. We also have anti-little c, which is fairly common with HDFN, and we have to think about that. So we know that The little c antigen is a higher frequency antigen, meaning that more people are going to have that antigen. So if we have a mom that lacks that antigen, very high probability that we're going to have a baby that inherits it from the dad, and then we get exposed to it, and just like the Rh system, or excuse me, the anti-D, little c, which is also in the Rh system, subsequent exposure to it is going to then cause that HDFN. You may have HDFN from antibodies to low frequency antigens. So we got to say, I've made an antibody to something that has a low antigen frequency. And because of that, the antibody screen on a mother may be negative, because we know that our antibody screen is only 3 cells, and if it's a low frequency antigen, all 3 of those cells are probably going to be negative for that antibody in question. So we can test the eluate against the father's RBCs. If it is ABO compatible, it may be helpful to cross-match the mother sample to the father's RBC to see if maybe the father was positive for an antibody to a low frequency antigen and thus caused the antibody production. So we're trying to predict HDFN. We have some testing to do that, so we're going to perform prenatal testing to identify women who may be Rh immune globulin candidates. We also want to identify women who have clinically significant antibodies. So for blood bank prenatal testing, we're going to do our ABO and Rh. We're going to do our antibody screen. We're going to do the antibody ID and the antibody titer if indicated. And if we look at page 250, and table 11.2, that's not right at all. So if performing an antibody titer, it's going to happen when a clinically significant antibody is identified. Some facilities do the antibody titers if any antibody is identified, whether it's clinically significant or not. But we want to perform a baseline titer at the time of the antibody identification, which is to say we do a screen that's positive, we do a panel, identify the antibody. We want to do that baseline ID with that current sample. Then we're going to freeze this sample for parallel testing to be done every 4 to 6 weeks. We're going to monitor the increase in titer, and then we'll test the parallel with previous frozen samples. And we're looking for a greater difference in the frozen sample to the current sample of greater than 2 dilutions. My facility doesn't monitor it with the frozen samples. We will look at the current sample based on our previous results because we use a uniform technique. Getting into that, performing the antibody titer is a simple 2-fold serial dilution of the patient's plasma with the antigen positive red cells. So what we're doing is setting up a number of tubes. It's 2 folds. It's usually a neat or undiluted sample, 2, 4, 8, 16, 32, 64, so on and so forth, up to usually 20, 48, and then further if we need to go higher than that. We'll take the patient's plasma and we try to use the homozygous expression of these antigen positive red cells to get the most sensitive response. The result we're going to get after we set this up in the same way that we've identified the antibody, we're going to see the reciprocal of the highest dilution showing a macroscopic agglutination. Most facilities have this set up as the last 1+ reaction in tube. Some places also have a titer score reported based on the strength of the reactivity, with a 4+ being a 12, 3+ being 10, a 2+ being an 8, and a 1+ being a 5. Our facility doesn't do the titer scores. We just report out that last reciprocal highest dilution and show that. What we also want to do with these procedures, and like I mentioned before, a uniform technique is meaning that I'm performing the exact same method with the current sample as I did with any of the previous other samples. That keeps us from detecting any falsely high or low antibody titers because we're going to do it in the same method. A lot of these 2-fold serial dilutions in tube are performed in a saline technique where we don't add any lysis or enhancement medium to it. We simply just let it incubate a little bit longer so we're not seeing any differences in titer strength. To determine the value of a critical antibody titer, this is going to be set by the facility's medical director and the patient's physician. Usually with Rh antibodies and others, they're going to set it about 1 to 32. With K, it's usually 1 to 8. Again, these are the critical values, but we also want to pay very close attention to if it jumps greater than 2 dilutions at one time. If it goes from, a 1 to 4 to a 1 to 64, we pay very close attention to that. So some of the monitoring that takes place of pregnancies with possible HDFN, looking at the patient history, the antibody titer, the ultrasound, the amniocentesis and lilograph, the chordocentesis or pubs, the fetal genotyping, and the paternal phenotyping. So for the patient history, we're looking at the obstetric history. Have they had any previous pregnancies? Have they have any previously affected infants? And transfusion history. Has the patient ever had blood before? With the ultrasound, a color Doppler can detect fetal anemia. We're going to see increased cardiac output and decreased blood viscosity. This is tested at peak systolic velocity at the midpoint of the cerebral artery. With amniocentesis, a long, slender needle is inserted through the mother's abdominal wall and uterus. Fluid is extracted from the amniotic sac and scanned by a spectrophotometer at 350 to 700 nanometers. The change in optical density is measured at 450 nanometers, and this measures bilirubin pigments, and this is plotted on the lilograph according to the week's gestation. So in measuring the severity of HDFN, the lilograph, we have that change in optical density at 450 nanometers compared to the week's gestation. If we look at figure 12.6 from on page 285, we're going to see an example of kind of where we are in the week's gestation and where that change in optical density takes place for, the intrauterine death risk. So the decision based on these results, but we can continue the pregnancy without intervention, we can perform an intrauterine transfusion, or we can induce an early labor. And if we're inducing an early labor, we're going to determine if fetal lungs are mature enough or if we need to give them a little bit of boost with some steroids. For a PUBS, or a percutaneous umbilical blood sampling, or a chordocentesis, fetal blood sample is obtained using ultrasound guidance to draw blood from the umbilical vein near a point of placental insertion. This carries a higher risk of fetal maternal hemorrhage and a 1 to 2% mortality rate for the fetus. A sample can be used for direct hemoglobin measurement and DNA testing to determine genotype. With molecular testing, fetal DNA can be obtained from the mother's plasma during the second trimester. Molecular testing can be performed to determine if the fetus lacks the antigen that would react with the maternal antibody. This avoids the chordocentesis collection. For postpartum testing, we have cord blood studies. Cord blood is collected at the time of the delivery, properly labeled and stored. Testing usually done on cord blood includes neonates from Group O mothers, neonates of Rh negative mothers, and neonates that show signs of hemolytic disease of the fetus and newborn. Rh immune globulin studies are performed on the mother if indicated. When performing cord blood testing, we must first wash the baby's RBCs 4 to 6 times to remove Wharton's jelly. It's a very common question you're going to see on the registry and potentially on the test, is that if you're testing cord blood, you got to wash it 4 to 6 times to remove that Wharton's jelly to get potential false positive reactions. We're going to perform the forward ABO only because not a whole lot of plasma in there, but any we see from this cord blood is going to be maternal antibody. An RH will include a weak D if the mother is Rh negative, and an IgG DAT. An elution is indicated if we have a positive result. We're going to do anti-IgG for the DAT with a saline control. We're going to interpret this with caution because if intrauterine transfusion has occurred, the baby may appear to be Rh negative. So an interesting thing occurs here called the blocking phenomenon, which may cause that baby to appear to be negative. So we can get this false negative reaction from having anti-D on the fetal cells, which causes a positive DAT due to the maternal anti-D. The antigen sites are blocked from reacting with reagents because the sites are occupied and fully saturated with the maternal antibody. An elution should allow harvest and ID of the antibody. So what we're going to see here are signs and symptoms pointing to having these issues, but we're having negative results. So we may have a blocking phenomenon happening. So ROGAM studies done on a maternal sample. With postpartum, we're going to do the ABO and RH, the antibody screen, and the fetal bleed screen. Antenatally, we're going to do the ABO and RH and the antibody screen. And anything involving trauma or abortion, it's going to be the same as the postpartum, but the fetal screen may be omitted if it happens in the first trimester. So here are some issues where you would not be a candidate for ROGAM or Rh immune globulin. D-negative women who deliver D-negative infants. Remember, a weak D test has to be done on these Rh negative pregnant patients. D positive women are not going to be candidates for RhoGAM because we shouldn't be making an anti-D. And Rh negative women with immune allo anti-D. The titers of these are generally greater than 4, and not to be confused with the passive anti-D acquired from the antenatal administration of RhoGAM. Again, these are usually stronger reactions. The passively acquired anti-D is usually weaker reactions. But if someone does have an alloimmune anti-D, they're not a candidate to get RhoGAM. So more about the Rh immune globulin, RHIG, sometimes called RhoGAM. It is a pool of IgG anti-D. This can give given by IV or intramuscular. One dose, or 300 micrograms, protects against 15 milliliters of D-positive RBCs, or about 30 milliliters of whole blood. This is given antenatally at 28 weeks, postpartum within 72 hours, and anytime an invasive procedure or trauma occurs within 72 hours, you want to give them a Rh immune globulin. I can't tell you how many patients I've had that look like they have an anti-D, and I ask, are they pregnant? Yes. Did they receive their 28-week immune globulin? Yes. Well, then it's probably a passive anti-D. Why are you sending it to me at this point? For the fetal bleed screen test, also known as the Rosette test, it's a qualitative test. RBCs from the mother are tested with a chemically modified anti-D reagent. Any anti-D in the system will attach to those D-positive RBCs in the maternal sample. The test is incubated, washed, with special indicator cells added. The indicator cells will attach to the sensitized D-positive RBCs and form microscopic rosettes. This can only be performed on Rh-negative mothers with Rh-positive babies or babies whose Rh is unknown. If the fetal bleed screen result is negative, we're going to administer 1 dose of RhoGAM. Remember, fetal screens can only detect bleed sizes of 10 mLs. So if we have a bleed of less than 10 mLs, it's going to appear negative. We're going to get them run 1 dose of RhoGAM. If it's positive, we must quantify the size of the bleed with a Klein-Hauer-Beckie stain or flow cytometry. With the KB stain, this is done to determine the extent of the fetal-maternal hemorrhage in Rh-positive patients. It's performed most commonly to quantify the dose of RhoGAM needed when fetal bleed screen is positive on a sample from an Rh-negative mother. Sadie is emphasizing that point. It is a quantitative test. A summary of the Klein-Hauer-Beckie stain method. So we have fetal hemoglobin F is more acid resistant than adult hemoglobin A. So a sample of postpartum blood is used to make slides. Slides are submerged in an acid solution and then stained. Hemoglobin from the adult cells leaches into the buffer, leaving behind only stroma, also known as ghost cells. These fetal cells, which are more resistant to the acid, remain a dark pink. For the calculation, we're going to count the number of adult cells and fetal cells until the count reaches 2,000. We're going to take the number of fetal cells counted, divided by that 2,000 total counted, times 5,000. This is going to be the fetal maternal hemorrhage. You take that number and divide it by 30. That's going to be the number of RhoGAM doses we need, and then we're going to add one more. So, when we get that decimal, if it's greater than 0.5, we're going to round up and then add an extra dose. So, if it's 3.5, we're going to round to 4 and then add an extra dose, so they get 5 total. If the decimal is less than 0.5, we're going to round down and add the extra dose. So, again, if we have 3.5, we're going to round down to 3, and we're going to add 1, making it 4. Even if the Klein-Hauer-Beckie stain is negative, we're going to give 1 dose of RhoGAM. So if we need to do an intrauterine transfusion, they want to select specific products usually for this. So normally, Group O Rh-negative RBCs, universal donors, especially for babies. We want them as fresh as possible, and most places like them to be in a CPDA1 solution. Now, if we have a patient that has a positive antibody, sometimes finding O-negative, less than 7 days old CPDA1 units is an impossibility. So they may take it suspended in a different suspension, but research has shown, for the most part, that they get a slightly better result from a CPDA1 solution as opposed to an AS5 or an AS3. Other studies will suggest that it literally doesn't matter and that using 7-day-old blood is the same as using 17-day-old blood. Neither here nor there. Most places are still going to order it less than 7 days old in a CPDA1, but I digress. We're also going to ask for it to be irradiated, leukocyte reduced, CMV negative because we're not trying to give them any sort of exposure to a virus, hemoglobin S negative, and it's going to be cross-matched using the maternal sample because these babies do not have a competent immune system yet. If you're doing an intrauterine transfusion, it carries a 1 to 3% risk of fetal demise. It's not really feasible prior to 20 weeks gestation, and once it's started, it may need to be performed at regular intervals until the delivery is possible. We may need to go beyond a simple transfusion into an exchange transfusion. So we want to determine the neonate's ABO and RH, and we're going to use the serum from the neonate or the maternal sample for the antibody screen, antibody ID and cross matches, because it's one and the same, because the neonate's plasma is only going to contain maternal antibodies. If an antibody is present, the RBC selected for transfusion will need to lack the corresponding antigen until the maternal antibody is cleared. So if hospitals are sticking to their guns of asking for O negative, less than 7-day-old, CPDA1, CMV negative, so on and so forth, asking for an antigen negative on top of that sometimes becomes a real hardship to find. And if it's going to cost the baby to take more time in order to get that intrauterine transfusion, they may lessen and slack the needs, especially if we're going to give them antigen negative blood. Because you would definitely want to give them antigen negative blood as opposed to saying, oh, well, we don't have CMV negative. We would definitely want to make sure that the blood is negative for the antibody in question. We're going to use plasma to reconstitute the RBCs to a hematocrit between 40 and 50% with group AB plasma. Why AB plasma? Because it does not have the anti-A and anti-B that normally occurs. For the RBCs, again, we want leukocyte reduced, irradiated, CMV negative, hemoglobin S negative. Anytime I see this order that comes up, I go, this is for a baby. You may also need to do a plasma exchange. We might need to do this to correct anemia. We can do a plasma exchange to remove the sensitized cells and replace them with normal donor cells. This will reduce the bilirubin level and reduce levels of the maternal antibody. And finally, we have fetal and neonatal alloimmune thrombocytopenia. This is caused by antibodies specific for platelet antigens inherited from the father that are lacking in the mother. This may require intrauterine transfusion. The neonate may be born with symptoms of pachychia or ecchymoses or intracranial hemorrhage.